Hi, this is Marit Milo, editor of the Silicon Valley San Jose Business Journal. On September 17th, we invited the leaders of 4 major Silicon Valley hospitals to join us to discuss one of the hottest topics in the country, healthcare reform, and to talk about how they might affect their institutions. With us were James Dover, CEO of OConnor Hospital; Bill Piché, CEO of Good Samaritan Hospital; Kenneth Graham, CEO of El Camino Hospital; and Kim Roberts, CEO of Santa Clara Valley Health and Hospital System. Our publisher, James McGregor, moderated the discussion with our panel.
I want to begin with a question for all of you, and a couple of you talked about this in your opening remarks. How has the economic slowdown impacted your hospital? And Jim, I'll start with you.
Well, I think that it's, from an economy standpoint, it's really as difficult times for the entire country. And our approach has been, in difficult times, I think everyone has to do their part. Mm-hmm. I failed to mention at the beginning, I want to make sure I get this in, is that we are a Daughters of Charity hospital. And so when we were founded, the Daughters of Charity, who still sponsor our organization and was founded by St. Vincent de Paul, is that we'll take care of everybody regardless of their walk in life and where their current status is in life. So what we have seen also, as I'm sure the other facilities have seen, is an increase in the uninsured. People who used to be insured had a job, they don't, they no longer, COBRA ran out. So what we're finding is we're having to find a better way to provide ongoing care even though they're coming to us episodically. So that's what we're finding has been one of our biggest challenges.
Okay. And Bill, how about you?
I mentioned the capital investment that we were making and continue and need to make, but I think the thing that comes home the quickest to me when you ask that question is the level and the rate of our capital spending has dramatically slowed. It is every capital dollar is really being looked at, although we're in a planning process, and in the state of California, the planning times are horrendous in terms of idea to actually implementation. So the impact on capital has been significant. The other area that we have emphasized because of the recession is just operations. How can we improve our process to improve patient flow through the hospital? And secondly, how can we keep our operating expenses as low as possible? Because the insurers are pushing back. We're just not getting the kinds of revenue increases on our managed care contracts that we have in the past. Mm-hmm. So to maintain our operating margins in the slowing economy really requires a lot of attention to operating costs.
I want to come back to this capital spending in just a couple of minutes. Kim, you talked a little bit about it, but
the term I think I use often is ringside seats.
Okay.
In terms of what's really been the impact of the economy. I mean, as people may be aware, there are currently 140,000 people in this county that have no health insurance, and that number has gone up dramatically. There are another 250,000 people that are what I would call underinsured. They have some sort of governmental assistance, Medi-Cal, healthy families, healthy kids. That's 400,000 people in this community that are struggling around basic healthcare issues and access to healthcare. And one of the outcomes of that is turning more and more to emergency departments. As I mentioned a minute ago, we've seen a 35% increase in volume in our emergency department. And there are things like a gentleman who arrives in pain and only to discover that it's his blood pressure, that he lost his job, lost his insurance, and no longer could afford his blood pressure medication. So he turns to the emergency department for care. Emergency departments treat first and figure out how you're going to pay later. I mean, that's not only a federal requirement, it's also an ethical requirement. But that creates a real dilemma at the very time our resources are being cut.
And Ken, finally with you.
Yeah, we've been doing our best to avoid the recession. The construction project has really been an imperative, and in that we have had to redo some of our long-term financial model. We avoided a $50 million debt and increased our cash flow by $2.5 million. We worked with the insurance companies to try to shift our expense over to inpatient services and reduce our exposure to outpatient services where we see a drop in elective procedures. We've held our prices still since July of 2008, and we will intend not to touch them again until at least next year, perhaps beyond that. And we've seen certainly some moderation and effect on our independent physicians who have been affected by lack of elective procedures, and actually some restraint by people who are avoiding health care because they don't feel they can afford it. In general, I think we are seeing an unfortunate response in the discussion about health care reform, because it has gotten wrapped up in this issue of the recession, and I think it has in some regard put more pressure and a more shrill voice on the topic.
So with the things you've talked about here, has it impacted any of your abilities to deliver quality health care? I mean, has it hurt the patient?
In our organization, I mean, quality is a threshold issue. I mean, if anything, we have a number of initiatives. I mean, how does quality get better and better? And there's a lot of actually national metrics and a lot of national attention on actually trying to measure quality in healthcare, which is difficult at best, you know, given the complexity and variety of people that we treat. But quality can never be the pawn in the game, if you will. What really stands in the balance is how many patients we're actually able to care for. And are we put in the circumstance of actually turning people away from basic healthcare services as our safety net grows bigger holes?
Okay.
You know, it's kind of interesting. Thinking about that question, looking at how the economy has been over the last couple of years and the struggles, but actually our quality is up, not down during this time period. It's fascinating to watch the clinicians and the nurses continue to find ways to raise the bar. I mean, our core measures are up, they're not down. We're doing better than we were 2 years ago. Our door-to-balloon times on STEMIs, and I'm sorry.
And for those of us not in the healthcare.
Sorry. When you come in and you've got a heart attack, we need to put a stent in.
Okay. We
measure the amount of time it takes to get that catheter in and reperfuse your heart. So, but actually our results are up, not down. And I would just encourage everyone to read. There was a great book written in the early 80s by a man by the name of Crosby. It's called Quality is Free. And if you do it right the first time, you're not paying for rework. And I'm sure many in the construction field understand that. Right? If you do the plumbing right, do the electrical right the first time, you're not paying someone to come out for a warranty call. And we're finding that that's a very important aspect of our approach to quality.
Okay.
I think more and more of our patients and our staff are really attuned to quality. I think the patients that we customarily see, their expectations regarding the value of the dollar rendered for services are increasingly going up. They want the very best. They don't want any glitches, which is always a challenge in a large, complex organization. And I think our staff has really responded to that. Much like Jim, our core measures, which are national indices of quality, continue to go up. And I think that's been one of the positive flips of this recession is quality, even at an economically stressful time, has been remarkably better.
Ken, yes?
There's been some opportunities caused by this external force that really has allowed us to do some things we wouldn't be able to do under ordinary circumstances. In our service approach to the emergency room, we've reduced our wait times by 40%, and we've cut 2 hours off our door-to-bed time. And the throughput and the efficiencies that come from that would have been hard to negotiate when there weren't the outside stresses.
Okay. I want to turn to the issue of reform. I think that's why a lot of you are here this morning. And this is a question for the four of you and for everybody here. Is there anyone here who doesn't believe that we should move to universal health care coverage?